Hi, everybody. This is Scott Youngquist, Medical Director for Salt Lake City Fire Department. This is a brief CME on heat stroke, and this is not a common problem, although it is common in the United States in the month of August. August is the most dangerous month for heat-related illness, and heat stroke is the most severe type of heat-related illness that you will see. So I'm going to base this on a case that I saw as an emergency physician, and we'll kind of talk about heat stroke and what to do with it, why it makes people so sick, and what you can do in the field for patients. So the objectives are we're going to talk about the definition of heat stroke. We're going to talk about some of the populations that are most at risk of heat stroke. We'll review some of the differential diagnosis of hyperthermia and altered mental status. This is more of hospital consideration. The main differential diagnosis in our population, the pre-hospital population, is going to be those other rapidly fixable things that cause altered mental status, such as hypoglycemia and hypoxia. The rest of it's going to be unobtainable to us many times in the field, although there may be some important history to obtain in the field setting. We're going to talk about some of the complications of heat-related illness, particularly heat stroke, and some of the treatment options available both in the pre-hospital setting and once the patient arrives to the emergency department. So this case was a 5-year-old male that presented via EMS to the emergency department. The call-in was that this was a patient who was found unresponsive after being discovered in the trunk of the family car. This car was parked on the street, and this was actually in May of this year that I saw this patient. I was covering a shift in a small emergency department in Logan, Utah, and the ambient temperature outside was only in the 50s, maybe low 60s at most. But these cars can heat up really fast. And what happened was the family had seen the kids they didn't know, 15 to 45 minutes before. The history was unclear. But the older daughter, and her boyfriend decided to go sit in the car and listen to some music. And they heard some stirring from the trunk and opened it up and found this child. Anyway, he was brought by paramedics, limp and panting and unresponsive, and placed on the gurney in front of me. Here were his vital signs. His initial rectal temperature was 43 degrees Celsius. So the kid was hot. His blood pressure was 75 over 32. And recall in pediatric ALS, the blood pressure, normal blood pressure for a 5-year-old is 70 plus 2 times the age. So this child should be at least 80. So he's below his marginal blood pressure. And this is hypotension for a pediatric patient. Heart rate of 208, that's high for a 5-year-old. A 5-year-old's resting heart rate should be, at most 100, but not 208 certainly, and the respiratory rate of 44 is quite high. But he was satting well on room air. His GCS was poor. This kid was moaning, would not withdraw to pain, would not spontaneously eye open. He had dry skin, and that's a bad sign. Somebody who is not sweating, who's that hot, means that stuff is shut down. Although pediatric patients don't sweat a lot in general. You don't see kids at soccer games who are 5 years old covered in sweat. They do sweat some, but they're poor sweaters at that age because they haven't developed those glands. Noted the tachycardia and tachypnea and some dry mucous membranes. He had a delayed cap refill that went along with his low blood pressure. The other thing to check in this patient, which wasn't done in the pre-hospital setting, but we should do aside from their vital signs, is a rapid glucose. And in this case, it was normal. It was 120. I mentioned some of this additional history. The family found the child in the car. He was quickly placed in a tub of cold water while they awaited EMS arrival. But nothing else was really done in the pre-hospital setting except getting him expeditiously to the hospital, which is okay. So the differential diagnosis, obviously, number one is heat stroke in this patient, but there are some other things that can cause a really high temperature and altered mental status. And these include things like neuroleptic malignant syndrome, and that's a rare adverse reaction to antipsychotic medications. And so it's good to get the medication history from the family or the patient if they can participate and figure out if they're taking something like this. Malignant hyperthermia, we're not going to see this in the pre-hospital setting, but it's on the differential diagnosis, and this is a weird reaction to things like succinylcholine. Succinylcholine or halothane, the other inhalational anesthetics, can cause in genetically susceptible individuals, this syndrome of hyperthermia and rigidity. The other one is serotonin syndrome. This is something that some of our paramedics recently saw when they responded to a call for altered mental status. This is a patient who was taking too much of his serotonin reuptake inhibitor, some sort of antidepressant. He was doing this to try to control hallucinations and ended up with serotonin syndrome. And this is some hyperthermia, some rigidity and spasticity. There's usually some GI symptoms, diarrhea. There are tremors and altered mental status. Some of the toxic overdoses can cause symptoms like this. Aspirin can cause severe hyperthermia and altered mental status. And that's because in high doses, aspirin uncouples the mitochondria, which, as you know, produce ATP, or the energy of your cells. It can uncouple the process of oxidative phosphorylation, which transfers electrons until they form ATP. When aspirin does this, it basically turns all those mitochondria into resistors, and as you know, when current passes through resistors, it causes heat, and that's why this can cause the patient to become hyperthermic. Anticholinergics and sympathomimetic ingestions can cause the same thing. Sympathomimetics are things like cocaine, methamphetamines, MDMA, or Ritalin, things like that. So patients who are taking Ritalin are at increased risk of heat exposure-related heat illness. Sepsis, so if this is some sort of infection, usually the temperature doesn't get above 42 degrees with sepsis, but it can in rare cases. And thyroid storms. So this is somebody who's got a very active thyroid that's going off, and that's not going to be something we're going to diagnose in the pre-hospital setting, but it looks very similar to this. And then finally is something called hemorrhagic shock and encephalopathy syndrome in pediatric patients. That is a descriptive syndrome because nobody knows what causes this, but you see high temperature as part of that syndrome. And then finally, status epilepticus. If somebody is seizing for enough time, they're working those muscles out continuously, they're going to have a fever and can develop a very high fever from that. So here's a definition of heat stroke. Anything less than this that's related to heat is called heat exhaustion, but this defines heat stroke, which is the most severe manifestation of heat-related illness. So you've got to have at least a core temperature of 42 degrees Celsius, that's 104 degrees Fahrenheit. You have to have a history of environmental heat exposure, and you have to have some degree of CNS dysfunction. The CNS dysfunction can be mild. It could be some mild confusion or memory problems, or it could be as severe as this pediatric patient I saw that was pretty densely comatose. Now, the temperature obviously can change with intervention, so if you are treating the patient or they are being treated at a football field or something like that, when you respond, their core temperature may decrease below 42 degrees, but that doesn't mean they didn't have heat stroke. So it's important to keep those things in mind. How does this happen? Well, your body has to balance both heat dissipation and your own heat production and maintenance. And when those get out of whack, you get heat-related illness. So on the left side, you see heat dissipation. The main way that we dissipate heat is through evaporative processes. In other words, we sweat. As that evaporates, it takes off heat from us. There's some other mechanisms known as radiation and conduction and convection. These are less important as evaporation or being able to sweat. Now, as I mentioned, pediatric patients don't have well-developed eccrine sweat glands, and that's nice for them because they don't have to wear antiperspirant and deodorant. They're not stinky adults like we are, but the downside is that they don't develop evaporative cooling as well as we do either. So when they're out in the heat, they don't cool down as much from the evaporative cooling as we do as adults. On the heat production and maintenance side, metabolic activity, that's your own body making heat because of the process, like I said, of making energy or ATP. There's some of that is turned into heat. And in pediatric patients, they've got a much higher metabolic activity, so they generate pound per pound much more heat than an adult does, and that's why they're more susceptible to heat-related illness as well. But you can also boost your metabolic activity by taking things like cocaine or Ritalin, things like that will also boost that. Humidity is an important consideration because that's going to keep heat in. If you are in a humid environment, approximately around 75% humidity, you're no longer able to use evaporative sweating for heat loss. So you can sweat all you want, it just doesn't go anywhere. It sits on you, it's sticky. So if you've been to Hawaii on a really humid day or to southern Florida, that's where you're at higher risk of heat-related injury because of that really high humidity. Body fat content, if somebody is very overweight or obese, they're at higher risk of heat-related injury. And then body surface area is an important consideration because pediatric patients have a higher body surface to mass ratio, and so they have more absorbable surface per pound or per kilogram to absorb heat than adults do. Anyway, that's the background of why patients get into trouble with heat-related illness. Now, I don't know if any of you recognize this guy. This guy's name was Corey Stringer. He played for the Minnesota Vikings and was a Pro Bowler. Died in 2001 in summer training camp in August due to heat stroke. The day before he died, he had to sit out because of heat exhaustion, and then he went back to play the next day and collapsed, was taken to the hospital with a temperature of 43 degrees and died of multi-organ system failure, and that was the end. Earlier in the same season, a freshman player at Florida died of the same thing. The populations most at risk for this, most at risk for death, I should say, are the elderly and the obese, although this is most commonly seen in children and adolescents. Elderly can't tolerate well these extreme temperatures. They don't have as much physiologic reserve as kids do, so they're more likely to die from this. But children and adolescents are the ones who are out playing the soccer and football and stuff like that in the hot summer sun. So they're the ones most likely to be affected by heat-related illness. This is a recent report from Morbidity and Mortality Weekly Report, this table over here. And they basically found that the highest risk is in high school football. It's in the South, it's in August, it's in the high school age group. Another population that is seen in the south of the United States along the border towns is the immigrant population. So this is a picture from Pima County of a dead body found decomposed in the desert from somebody who's trying to cross into the country. And they find about 180 of these bodies that they can't identify every year in Pima County. There's an entire morgue devoted to heat-related deaths along I believe it's the Sonoran Desert, but not absolutely sure. But that desert stretch along Pima County, Arizona, in the south. All right, so here's a concept, the critical thermal maximum. This is the degree of temperature elevation and duration before which cell death occurs. And this is determined to be about 42 degrees Celsius. That's why that's the definition of heat stroke, is you got to be at least 42 degrees. And that temperature has to be maintained for anywhere from 45 minutes up to 8 hours. Now, some people are acclimatized to high temperatures, and you can acclimatize your body to high temperatures slowly, just like you can acclimatize to altitude. Once you're acclimatized, you can withstand longer periods of higher temperatures than if you're just going out into the heat for the first time. But somewhere around 45 minutes for the physiologically naive person at 42 degrees is where cell death starts to occur. What happens is, as temperature and time are mixed, you get the same thing you do with aspirin overdose, this oxidative phosphorylation uncoupling, so that on the cellular level you start to produce your own heat, and the enzymes that are critical, these little proteins that are critical for carrying out functions within the cells, become denatured. It's just like you see proteins denatured when you cook up an egg. That's all a bunch of protein that's becoming denatured. And so those no longer participate in the cellular processes. The cells that are most at risk are found in the liver and in the gut and in the brain. And as those become hit, you begin to experience multi-organ system failure and death. And so it's a cascade that goes progressively from one end of the spectrum to the other. Complications that are seen, hypoglycemia is one, especially in pediatric patients, so check a glucose and administer sugar as needed in these patients. One of the reasons for this is that your liver is the store of glucose for the rest of your body, and so if that takes a hit, it can no longer provide glucose. Metabolic acidosis occurs. You get some anemia from breakup of red blood cells and disseminated intravascular coagulation. Um, Electrolyte abnormalities, so you may see a low sodium, you may see a high sodium, a low potassium, just depends on the clinical context. Liver damage may be seen in these patients. Rhabdomyolysis, which is breakdown of muscle. Breakdown of muscle puts toxic products of muscle into the bloodstream, which can clog up the kidneys and cause acute renal failure. I misspelled complications, I just noticed that, but toxic ingestions, while this is not a complication, you should consider this, for example, in patients who may have potentially had an aspirin overdose. It's important to get a history of any medications the patient may have taken, or notice on the scene if there are empty bottles of anything. And then patients may have intracerebral hemorrhage or brain swelling from this as well. So treatment is very simple. It's going to be your ABCs, but in addition to that, the other mainstay of therapy is to actively cool the patient. I'll talk about ways to do that. A little bit down the list are benzodiazepines and more supportive care. Those are things mainly done in the emergency department. Let's talk first about airway and breathing. These patients need airway protection. At some point they're going to, although I don't know that you need to intubate these patients unless their GCS is really low and it doesn't appear that they're protecting their airway. These patients frequently vomit because of their heat-related illness, so that's one reason to protect the airway. They have high oxygen consumption because of the increase in their metabolic processes because of the heat. They often have this metabolic acidosis, and as you may remember, the thing your body does to try to bring the pH back up is to compensate by blowing off CO2, and so they have a high respiratory rate. That makes it problematic to intubate them because if you take away their spontaneous breathing and you put them at too low of a rate, you're going to build up CO2 and add a respiratory acidosis on top of the metabolic acidosis. In the hospital, they may need to be paralyzed to prevent shivering, which will thwart efforts to cool them. For circulation, these patients often would benefit from some degree of rehydration, given the amount of heat exposure they've had and the amount of sweating they've probably been doing prior to this. So somewhere around a 20 to 60 cc per kilo bolus of normal saline is appropriate. You may need some more aggressive rehydration if they've had a prolonged downtime or they're hypotensive, but you can begin to give them fluids in the pre-hospital setting. Cooling is the other mainstay of therapy, and this is not high tech at all. You don't need anything that can't be found relatively easy in a hospital emergency department. Although having access to this stuff in the pre-hospital setting is obviously limited. But evaporative cooling is really the way to go. It lowers the temperature quite nicely and quickly, and it's shown to be very effective. And this is what's used in places like the Hajj in the Middle East, where you have all kinds of Muslim pilgrims that come and get heat-related illness, and this is what they've been doing for years to cool them. All you need is a spray bottle with some cool mist and a fan or some way to get that evaporative cooling going. So you may, if you have something like that on hand or some way to provide that type of care in the pre-hospital setting, you can begin to cool the patient in the pre-hospital setting. Sometimes at sporting events, you've seen that they have cool mist and fans there on the sideline, and that's to prevent this. Those can be used to treat these patients as well as you get them ready to go. Ice water immersion does do the same sort of thing, although that, practically speaking, is very difficult to do. You've got this altered patient that you're going to try to submerge in ice water. It doesn't. I can't picture it working either in the pre-hospital setting or in the emergency department. Nobody's really studied chilled saline. Would the chill core stuff work? Well, there's no reason to think it wouldn't. So one thing you could do instead of giving these patients room temperature normal saline is to use the hypothermic medication, the hypothermic saline that you've got in the chill core for the cardiac arrest patient, and infuse that rapidly. That should cool them, although, like I said, it hasn't been studied, and I wouldn't do it in place of evaporative cooling where that's available. They do have expensive intravascular cooling devices that can be used in the emergency department, but usually this is cooling that occurs pretty quickly. So you don't need a central line or anything like that to do that, but that can be done in the hospital setting as well. When are they going to stop cooling? Well, they're not trying to make these patients hypothermic, so in order to avoid overshooting, once the patient reaches a temperature of around 38 degrees Celsius is when they're going to be stopping the cooling and just continuing supportive care. Benzodiazepines are generally recommended to suppress shivering. This is probably not important in the pre-hospital setting so much, but if you have a patient who's agitated or combative, I would use benzodiazepines to calm them because it may have this added benefit of suppressing shivering while they're being cooled. And it may prevent seizures in these patients. These patients are prone to seizures because of the high temperatures. All these patients obviously need to go to the emergency department. These aren't patients that can be treated and then discharged from care. They need to be taken to the ED. All patients with heat stroke end up in the ICU, and the reason is because there's some delayed organ failure that can occur. So they need to go to a place where the care is best, and that they may have to be secondarily transferred from an emergency department where they can be stabilized initially. So what are the outcomes? As I mentioned, the mortality is worse in the elderly patients who can poorly tolerate this type of physiologic insult. So they're more likely to die than live when afflicted with heat stroke. And these are patients you may see in the summer months whose air conditioning has gone out, or they're out of money. They're poor pensioners who can't afford electricity or something like that, who get into trouble and either die in their homes or you find them in heat stroke. Death rates are much lower in pediatrics and in adolescents because they can tolerate these insults, although just yesterday there were 2 high school prep stars in Georgia who died of heat stroke. And it's August, so this is the month for it. The morbidity for these patients who do survive is mainly neurological, and that may be some discoordination or some other type of long-term neurologic problem. Some of these patients get what's termed heat intolerance, and it's basically an inability to regulate your temperature homeostasis, so they have wild fluctuations of temperature. They become less human and more like the gecko when it comes to their heat balance. As you know, lizards are poikilothermic animals who basically have to be in the sun in order to raise their temperature and have to be in the shade to lower it because they don't regulate their temperature internally very well. Well, they become much more like the gecko after a heat stroke, and that can persist for some time, so it needs to be watched by a physician. In this patient, this pediatric patient, we undertook evaporative cooling with mists and fans. I paralyzed and intubated the patient. Once the temperature dropped a little bit, the patient started to shiver, so needed to be paralyzed to prevent him from thwarting our efforts to cool him. We gave him a 60 cc's per kilo bolus and got his temp down to around 38.2 at transfer. He was flown from Logan to Primary Children's, and there he had some bumped LFTs, and they reported some bowel sloughing. He had some, again, the GI tract and the liver are the ones, and the brain are the ones that take the hit on heat-related illness initially. Had to be put on pressors briefly to maintain his blood pressure. They put him on some Keppra for seizure prophylaxis. After 3 days, he was extubated and was discharged after a fairly long hospital course. I thought he would leave the hospital sooner than this, just based on the improvement I saw in his neurologic status in the emergency department, but it took him 8 days to get him out of there, and he had to go to rehab for some discoordination, but is now normal. So